So now I am going to be talking about the coalition priorities going into 2021. And as the slide is being brought up for this, we were actually talking about this before COVID hit. So for those who have been involved in the coalition, a lot of what I'm going to be talking about and showing over the next couple of slides are going to be very familiar to you because these are discussions that we've been having really for over like a year before the pandemic hit. But but really, as we approach this, you're going to see there's a mix of policy priorities going forward. And by that, I mean, when we talk about policy, I think a lot of people automatically assume when we talk about policies, we're talking about legislation, we're talking about regulations, we're talking about government policies. But there's really two different types of policies. There's the legislation, statutory type of policy that you have, but there's also policy work that an organization can do that can help inform or help push forward or help implement the policies that the laws put into place. So what you're going to see is really a mix of that for our priorities going into 2021. Again, as I mentioned, if you have been involved with the coalition over the last couple of months, these are going to look very familiar to you, but we're just going to dive a little bit deeper into them. So first off, we have make temporary coverage expansions permanent and expand the modalities that we're using. Build the evidence base, make sure we bridge the digital divide, and advance state leadership on telehealth. So we'll go to the first one first. So making temporary coverage expansion, expand the access to new modalities. Again, this is something that is very familiar to all of us. I think most of the members would agree that we want to see these actions happen. That is to make these certain expansions that are temporary right now permanent, and then really held over from what we were discussing before the pandemic, expand access to modalities. That's includes remote patient monitoring, but now the conversation with COVID has also brought in the use of audio-only phone as well. This is where we're going to see a lot of our work involving that what a colleague of ours, Pat Powers, used to say is the capital P policy, the legislative type of work, the regulatory type of work. That's where the changes are going to happen. So some of the recommendations that we have going forward in order to meet this particular priority is to support payment parity for Medi-Cal managed care, again, something that we've been discussing for a while. Support remote patient monitoring, again, something that's held over before the pandemic. But we also want to talk about continuing the support for the FQHC and RHC changes. Before COVID-19 hit, FQHCs and RHCs were very limited in how they could use telehealth. They didn't have as much room to utilize telehealth with the expansive policies that Medi-Cal put in place last summer as the usual provider was able to do. Pandemic relaxed some of those restrictions, allowed FQHCs and RHCs to utilize telehealth more fully, allowed them to provide it into people's homes or patients' homes, allowed them to use audio-only phone as well too. We've heard from Beth Malinsky from California Primary Care Association of how important that is for her membership in order for them to continue to provide those services to their patients as well. So there's going to be continued support in ensuring that those changes, those relaxations actually remain permanent and stick around for the FQHCs and RHCs because it's vital for them to provide those services to their patients. But we're also going to need to do work that isn't necessarily your capital P policy work. It's not necessarily something that's going to be accomplished through legislation or through regulations or some sort of policy change on the Medicare administrative level side of thing. It is going to be work that the coalition needs to do to help push those types of changes forward. And among them is going to be highlighting the patient stories and caregiver stories. We mentioned that we did webinars that we had not actually been doing as a coalition before COVID-19. We did a series of webinars this year. We also have done legislative briefings and outreach, and also participated in other members' webinars as well. One of the areas where we got the highest praise for what we have put on has been highlighting those patient and caregiver stories. We need more of that because that is something that we have found that policymakers really respond to. They do want to know what has been the impact on their constituencies, and to get that information, they need to hear those patient stories. So the coalition is recommending that we work in order to help push the policies forward, work to gather more of those patient stories, have those patient voices heard more clearly and more often by policymakers and those in the administration as well. Next slide, please. Build the evidence base for telehealth in California. Now, there's a reason why we have two committees in the coalition. We have a legislative committee and we have an education committee. So the legislative committee, their work is very specific. It is on the legislation that is in California going forward, what bills to look at, what bills to support, and what bills to remain neutral or oppose. However, we have an education committee as well, and if you hear earlier today, you heard Julie Bates, who is our current chair, and she's cycling off now, talk about all the work that the education committee has done. And that is a broad scope of work. So they do the webinars, they do the fact sheet, they provide that education, that information to the group. We're going to also need that, as you also heard throughout the day, there have been calls by policymakers for evidence, like the data, the information. Dr. Chen even just mentioned that, of like having some of that data and that information provided to them. That is another way to push policy through. It's not going to involve necessarily like a piece of legislation that we support and push through. It is going to involve some work that the coalition itself needs to do in order to provide that information to help push another specific piece of legislation through. So examples of that work that the coalition will need to do will be such things as showcasing research in our monthly calls. We've encountered and met and invited some wonderful speakers over the last couple of months. Dr. Anaya, who you'll hear on the next panel from UCLA. We've had an NQF. We've had the Federation of State Medical Boards. All of them have provided information to the coalition and will continue to do that, because not only does that build the coalition sort of database or like base of materials in order to like answer questions from policymakers or to provide evidence or data for them, but it also increases the knowledge of each coalition member. So you have that knowledge as well to go forward if you get asked that question by a policymaker or somebody else. We also hope to try to develop a telehealth data clearinghouse on the website and leverage members' data dashboards. So we want to try to create a central location of where data can be accessed. There's nothing like that right now in California. There have been efforts by various organizations to like try to gather that data, have certain pieces of that data, but we hope, given our wide variety of membership in the coalition, to have those pieces housed in one location. So again, if the coalition gets asked by a policymaker of like, can you show me the data of X, we have somewhere we can pull from immediately, but coalition members also have access to that as well, where they too can like pull that information out if that question comes to them directly. I think releasing an annual report to align with our fall briefing of like the state of telehealth and what needs to be done each year would be extremely useful to policymakers. I'm not sure if all of you are familiar with the history of the coalition. So the coalition actually came about around due to a report that CCHP put together. It was the Telehealth Model Statute report back in 2010. We convened a working group, and this is actually where I met Peggy Wheeler when she said we really do go way back, where we convened a panel of expert panels to look at updating California law. CCHP took the recommendations, we did a report, and we also did model language for it. That model language was picked up by Assemblymember Logue, saying, I like these recommendations, I'm going to carry a bill forward. As that bill was going through the process, that was how the coalition was built, because a couple of member organizations decided that they wanted to keep in touch with each other as the bill went through the process, just to see what could be done and like to get updates. And that was how the coalition started. So it all came from one report to a major update to California law and the creation of the coalition. So we're going to look at trying to do that again, possibly, of like doing an annual report that can maybe serve as a basis, as a roadmap possibly for policymakers on what they need to do going forward for the following year. Host capital briefings. Our briefings have been extremely successful. We've had 2 in the past 2 years, and we've also had briefings in previous years as well. Each of them have been extremely well attended. We've gotten great feedback on them, and we've expanded our reach of speakers and members of the coalition from these events, and also relationships with potential policymakers. We hope to do that again. And we hope to continue our webinars. They've been extremely well attended, and we've gotten incredible feedback from them. And they provided that necessary education to the public out there, especially during COVID, when so many people were pivoting towards telehealth, were wondering what to do. They created basically a lifeline of that necessary, relied upon, and really vetted and accurate information for the public out there. Next slide, please. We talked a lot about disparities, and I love the comment that Peggy made, and I apologize if I'm not doing it justice and citing it accurately, but she mentioned that quote that she pulled up where they said that the fissures in disparities were not created by COVID. They've always existed. And I can feel that probably many people agree with her in that particular quote. The fissures there in the disparities already existed. COVID just highlighted them. What we do not want to do with any of our telehealth policy changes is to exacerbate those fissures. We want to use telehealth in order to overcome them, in order to try to solve some of those disparities, try to solve some of those access issues. But we definitely do not want them to create more disparities or to widen that gap. So again, some of the work that we are talking about there is our broadband work, because that is one of the things that has been noted during COVID that has caused an issue of a have and have not situation with telehealth, because people may not have adequate broadband access. It's one reason why the coalition has now a broadband work group. And for those who are interested specifically in this issue, I really highly recommend that you get on that work group. Just email me or Robbie, and we'll be happy to put you on. So that is something that we'll continue on going into 2021, because I do think it will become a major issue of discussion. We heard from Assemblymember Aguilar Curry. This is something she is extremely interested in. She has carried bills in the past on broadband. The coalition needs to have a role and a voice in that as well. Want to demonstrate and build the evidence base on the efficacy and quality of telephone visits. That is a major priority for a lot of members here. There's been a lot of discussion of it throughout the day, but there's still that hurdle for a lot of policymakers of, is it as good? Does it work? Should we be paying the same amount? A lot of questions, not just really on the state level as well, but on the federal level as well too. And I'm hearing it from other states as well of what do we do with audio-only telephone? Should we keep it? Should we not? How far do we go for it? So building that evidence base of what it can do, when it should be utilized, and providing that to policymakers to help them make their decisions. Track and highlight distribution of internet access and telehealth across communities. Again, we do not want to exacerbate disparities among different groups. And it's not just among income groups or geographic location, we're rural versus urban. We're also talking about communities of color, the disabled communities, older adults, teens, and young adults. We're talking about everybody. We do not want telehealth, as it goes forward, to leave anybody behind. Basically, our goal is to ensure anybody who needs access to services via telehealth can access them. So we have to ensure that the policies that we push forward, the policies that we support, do not inadvertently cause these disparities or to widen the disparities. And we want to identify additional resources for telehealth adoptions through grants and technical assistance. A lot of things we do here, again, in the whole digital divide discussion, is there's going to be some people who are have-nots. For whatever reason, for culture, income, again, location, they may not have access to certain things such as the equipment that you need, whether it's broadband or like a smartphone. We're going to try to see if we can identify additional resources in order to help them or encourage additional resources be put into those types of programs to ensure that that gap is not widened and that it's actually narrowed. Next slide, please. Advanced state leadership on telehealth and health IT. Again, we heard from previous speakers about a lot of the great work the coalition has done over 2020 in response to COVID. And we have taken a leadership position in the state. We've become more well known. We've become relied upon. We've had policymakers and their staff reach out to us saying, do you have this? Can you talk about this? We need to continue that momentum. And through that, we need everybody's help for it. So we need to ensure that we all work together. We need to advance or expand the base of our membership in order to include as many people as possible, but still work collectively together, coalition, to have as closely as possible one voice on the issues. So we're going to continue to advocate for state coordination of telehealth and related health IT issues. We're going to also continue to track our regulatory requirements and do regular updates. We're going to continue our outreach. Again, a lot of work that the Education Committee has done, so I recommend that if you're interested in this type of work, you get involved with our Education Committee. And we're going to emphasize the need to modernize telehealth and data sharing through state policy initiatives and work with the different initiatives that are going on the state level. As we go into 2021, there is going to be a lot of discussion around telehealth policies. There's going to be a lot of different groups who are working on it. We need to ensure that the coalition is involved in those groups, that we have a voice there at the table, that we bring forward our thoughts, our input into the various pieces of discussion and the policies going forward. So as you can see, there's a lot of work ahead of us for 2021. Not all of it is in that classical policy work of we're supporting a bill, we're writing or editing a bill, or supporting a bill and trying to push it forward. There's going to be a lot of internal work that we do in the coalition related to education, related to information sharing, relating to housing of this information, because these are all pieces that will help eventually push those policies forward. We have an incredible opportunity here with our policy slate, because there is this vast interest in telehealth, but more importantly, there is this need for telehealth as we go into 2021. So I think we may have our next panel ready to go, unless we would like to take one or two questions here before we go. We're slightly ahead of time. So do we have our next panel ready to go?
I think
there we
do.
go. There we go,
Yeah.
Dr. Majid. So
Awesome.
I will now turn it over to our wonderful Vice Chair of the Education Committee, Dr. Anthony Majid.
Yeah, and I want to thank May for this wonderful lei that showed at my house this morning. So really appreciate the gesture. So I think we've had an incredible meeting throughout the day, and I want to jump right into our panel because I think we have incredible perspectives, expertise that I'd like to share with you. Obviously, health equity is front and center conversation with what's happened the past several months in this country, and I think, as May alluded to, these disparities have existed in time immemorial, and that light has just been shed upon these things. So I think this is something that telemedicine clearly has the opportunity to correct and sort of close some of those disparities or exacerbate. So what I'd like to do is go ahead and start with our first panelist. Dr. Anaya has expertise in research in health disparity, and really looking forward to hearing your perspective on what you've found out through your research and your advocacy.
Thank you so much for having me. I am so pleased to be here, and I can really just say that I very much echo the priorities of the coalition, and hearing the importance of equity in our approach it is really heartening. As a physician that cares for both underserved patients in both the underserved safety net as well as kind of within the UCLA commercial side, I can begin to kind of speak about those disparities and the importance of us really taking a step back from what we were able to really launch quickly in the pandemic, to really take a step back and say, okay, how can we do this better? We've managed to make it happen. Now let's make it better so that we're not leaving out some of our most vulnerable populations. And care that is equitable is going to be readily accessible both in person and virtually for all individuals, regardless of linguistic, literacy, socioeconomic, cognitive, or physical barriers. And so, to speak about a little bit about some of those structural barriers that our patient populations are facing, our vulnerable populations are facing, unfortunately, we're already seeing the usual patterns of access disparities that truly favor young, affluent, non-Hispanic white populations. It's coming through in the literature, and we really are leaving behind our most vulnerable and already underserved patients. We know that disparities in healthcare access, just as were mentioned before, and quality of care, those have been extensively documented in the literature prior to the skyrocketing incorporation of telehealth. And so now we're at this time juncture that we need to now figure out how we can develop a system, improve our system so that we can really set up these telehealth ecosystems such that not only advantaged populations can use them and access them, but all populations can use them. So of course, first, technology, right? So the physical devices that folks have or don't have, but also the software that we require patients to use in order to access our portals, our virtual visits. So, Black and Hispanic adults remain significantly less likely than whites to own a computer or have high-speed internet at home. And so if the telehealth systems that we're employing require virtual visits or portal access to occur via a computer, you're physically excluding a pretty big segment of the population. But beyond having that physical device, telehealth requires that patients have prerequisite skills in using the needed software. We often call this digital literacy, but also, depending on generational related exposure and personal preferences, we need to be cautious of not leaving folks out because of their inexperience or lack of skills, lack of prior skills with using that type of software. And or supplementing that, right? So giving them the education in an accessible manner, ways that they are already accessing information such as things like YouTube, and also having support for them in our clinics, right? So not just somebody who is going to call them and let them know that it's time for their video visit, but actually somebody that can even walk them through getting onto their virtual visit, allowing them to give them that support when they run into an issue. I don't know how, what button do I push? It's really, it can be that basic. And then of course, for patients that have limited English proficiency. So, in California and the US, English, after English, Spanish is the most frequently spoken language in the United States and in California. And so thinking about how we can ensure that we have access for these patients at all points of contact, right? Telehealth systems should be no different. Specifically, we what further magnifies this issue is that we do have a very limited supply of language-capable providers in California and the United States, and that's what some of our research has shown is how Spanish-speaking physicians are the most underrepresented in the physician workforce here in California. And so all of these barriers are kind of just building upon each other, right? And finally, the barriers that providers are facing, they ultimately affect patients, and they're really affecting vulnerable patients disproportionately. So offices, safety net offices, not having the needed hardware like cameras to conduct their virtual visits, or not having the software to be able to launch a video visit. In our county system, our primary care clinic visits, we don't even have the option to do video visits really for the most part right now. And so needing to rely on telephone visits, and there comes the importance of continued payment for telephone visits. So a lot of issues that we need to start to think about in a more strategic way, but purposefully and strategically design telehealth will address these barriers and will achieve more equitable outcomes. And we can do it by using our resources wisely and considering costs. I think it's very possible. So I'll leave it there and allow the next speaker to make some remarks.
No, Dr. Naya, thank you very much for those insights, and your continued work in this field is incredibly valuable and going to be critical. I'd like to turn to Fabiola. In terms of your experience, what you're hearing from your Medicaid advocates in the field that sort of continues on with the themes that Dr. Naya was speaking about.
Sure. Hi, everyone. My name is Fabiola Carrion, and I work at the National Health Law Program. We are a public interest law firm that represents the rights of low-income and underserved individuals. Our bread and butter issues are Medicaid and the Affordable Care Act, and we have offices here in California as well as in Washington, D.C. and in North Carolina. What I would have to say about so our main constituency are legal aid attorneys. Those are the attorneys that offer direct services to low-income individuals. And what I would say about that population specifically is that they're very curious, but also really concerned about the possible, as May mentioned, exacerbation of disparities that can be caused by over-reliance in telehealth. What I would have to say about the coalition's priorities is that they align really well with our own principles on telehealth. Actually, we were largely inspired by the work that we have done with the coalition. I think that those principles on Medicaid and telehealth have been distributed, and I'm sure they can be made available. For us, we put ourselves in the mind of the consumer, of the enrollee, of the patient, in particular when that person is underserved or low income. Does that person want to have access to telehealth? Do they have the resources to do it? Do they have the equipment? Do they have the software? Do they have the connectivity? Do they feel comfortable engaging in this? Are they, digitally literate? Are they able to use the computer? Are they able to use the software? And it's not only just the patient, it's the caregiver, is the healthcare provider, is the parent, is the anyone who supports that particular patient, somewhat at a school. Are you getting the high quality services that respond to that patient's needs? Is it culturally competent? Do you have access to language interpreters? All of the things that Dr. Anaya has already discovered through her research. Obviously, it's something that we're deeply concerned about, and we echo previous speakers, request for more patient experiences research. I would say that for us, broadband needs to be considered a utility, just like anything else, just like we have water, just like we have landline phones, just like we have electricity. It's not something that should just be available to those with resources. I was really enthused by Peggy's call for being radical. This is the opportunity to be radical. And I think this conversation about broadband is not new. It has been happening for the last 10, 15, 20 years. And it's only now that people are taking it seriously. So I would love for us to look back into the work that has already been made around this campaign, this call for more broadband access. I think that we do have the opportunity to be aggressive. Landline phones a century ago were made available throughout the United States because we had a government that supported it, that called the phone providers at that time into action, that required them to do this. So to say that it's really expensive, or I don't know how to do it, or that we have a model, we have a 100-year-old model that we can look at. So I think that the coalition should join forces with other, broadband advocates across the country to make sure that this is available for broadband, for telehealth, civic engagement, education, etc. We also obviously we support the access of telehealth, but we join Dr. Chen's concern about making sure that telehealth does not necessarily replace in-person healthcare, but that it can complement or add to existing services. We understand that while telehealth is not the only solution for limited access to healthcare, it should be part of a long-term complementary and sustained strategy to address problems regarding access and convenience to the consumer. The other thought that we have as Medicaid advocates is the role that telehealth would play in managed care and network adequacy. We want to make sure that the use of telehealth does not derail network adequacy and other managed care protections. Returning to broadband, I just want to highlight a study or a poll that was conducted just, I think, last week that found that 30% of Black, Hispanic, or Latinos and other people of color who earn less than $50,000 a year have missed at least one payment on our internet bill since the pandemic started. This is compared to 14% of low-income whites. So this is very much an equity issue. This is very much, unfortunately, highlighting and exacerbating disparities, and I'm really excited to be part of this coalition. I have other remarks, but I will leave it to the rest of the panelists and to your questions. Thank you so much for this opportunity.
No, thank you very much. And I'd like to ask all the panelists, actually you can turn on your camera. It'll make it a little bit more dynamic for us, so I appreciate that. So that really, again, your remarks are really, very relevant and give us some guidance as where we can go forward. What I'd like to do is turn towards Kieran. We heard earlier from the California Healthcare Foundation survey of physicians, and I know that your organization has done a survey of patients, consumers, so to speak, and we'd really like to hear your perspective in terms of what you found in terms on the recipient side regarding telemedicine.
Sure, happy to, and thanks for the invitation. I'm with the California Pan-Ethnic Health Network. We're a statewide multicultural health advocacy organization, and we represent consumers. And one thing that we observed as telehealth was sort of rapidly proliferating during the pandemic is something that's been mentioned here, I think, a couple times, that there's really a gap in our knowledge of how technology is received and utilized by consumers, and particularly for people of color who we know have historically been left behind by healthcare innovations. And so we conducted an online survey in September, sort of our version of an online survey. I won't claim that it's super scientific, but we put it out there, right? We put the question out there to folks. We have completed responses from nearly 1,700 consumers in California. We did the survey in English, Spanish, Chinese, and Korean. And we purposely oversampled particularly Black, Native American, and Pacific Islander communities because small populations are often overlooked in our research. And I think, when we look at it, we saw that of these nearly 2,000 consumers, most had accessed in the last 12 months primary care using telehealth, but about 20% had accessed specialty care and 10% had access to mental health or substance use disorder treatment. About half had used video for their care, about a quarter had used phone apps, and about 20% had used their phones, either their cell phone or their landline. And I would say, to answer the direct question, the findings are, I think, fairly similar to what CHCF found, except for that we are able to look by specific population and compare and contrast. But in general, I think similar to the CHCF findings, we did find high satisfaction with telehealth among people of color. In our survey, Black respondents were most likely to report satisfaction, and all of the populations that are people of color were actually more likely to report satisfaction with telehealth than our white respondents. Most respondents felt that telehealth was better than they had expected. And most respondents stated that they would prefer telehealth over in-person visits in the future. But I would note that this did have wider variation among populations. So about 70% of our Black and Pacific Islander respondents stated that they would prefer telehealth in the future, but only a slight majority of our Latino respondents also share this preference. So there's an important difference to pay attention to there. And we also asked consumers about the challenges, right? Because we understand that while there's potentially significant opportunity here, we really need to pay particular attention to the challenges and the barriers if we're not going to widen the inequities and the injustices. So some of the challenges that really rose to the top in the survey, one is privacy. So about a third of our respondents, and led by Asian, Pacific Islander, and Native American respondents, reported that they don't have a safe and private place to take their appointments when they need to. That's not something that they have access to, and that's a concern for them in using telehealth. I really want to also call out the issues that we heard around language access. Because among our non-English speaker survey respondents, a majority did not receive any language assistance with their visit, which was surprising to me because I'll say, not being someone who knows a lot about telehealth, I thought, okay, technology, it should be so much easier to coordinate these things. But it's not happening, and I think to have a majority of folks not receiving language assistance is a really significant problem in the state of California that we need to pay attention to and that we need to figure out before there's a further expansion of telehealth. Also, 40% of our respondents reported that they didn't receive any assistance with their visit. They didn't get instructions for how to use video. They didn't get help understanding how to communicate with the doctor, what to expect, et cetera. And so that's something, too, that I think we need to pay attention to if we're going to continue to grow the use of the technology, is that we need to make sure that consumers are empowered and have the information that they need to feel engaged in their care through virtual technologies. And the digital divide has been pretty extensively discussed today, right? So I won't go too far into it, but I would say in our survey, Latino respondents were most likely to report challenges accessing the internet, followed by our Black and Native American respondents. And the majority of Latino respondents also reported that they don't have enough minutes on their phone to access their visits via phone. So I know the previous speaker talked about this a little bit as sort of, I think, access to technology, access to phone minutes really needs to be a right when we think about healthcare if we're going to be encouraging the use of telehealth, although we would certainly agree that it absolutely must be a consumer choice. And that if we're going to continue to expand the technology, we also need to make sure that consumers are going to have access to the tools and technologies that help them be engaged in their care from home, whether that's blood pressure, cuff scales, et cetera. And I do want to say, because, you know, we approach this obviously from an equity perspective, and I know there's been a lot of discussion about disparities, which I really consider inequities or injustices. And I think we need to remember that when we talk about health equity, we're really talking about systemic and structural and institutionalized racism, which is to say that our health systems are producing exactly the results they were designed to produce. And if we want to see different results, we really need to think about how do we significantly shift the balance of power within healthcare. Our health systems are not currently designed to center patients, and we operate as a hierarchy that consumers have to adapt to navigate and access in a way that's not necessarily relevant or helpful to them. So we do think that telehealth, if we really put a serious focus on health equity, can be a piece of the solution to changing that and to really putting consumers at the center and in charge of their care. But that must be a laser focus of our efforts here in order to really see success in that. So I'm happy to answer any questions as we go on, but thanks for the opportunity to be here.
No, Karen, thank you very much. And that brings up so many critical issues. I'm thinking about how physicians are trained to deliver telemedicine. Pre-pandemic, one of the barriers identified was the comfort that physicians had with telemedicine and the concerns regarding quality of care. I'd like to hear Gianna's thoughts, having spent a great deal of time in academic institutions, about what you foresee in terms of preparing the next generation of telemedicine providers, both from a technical standpoint, as well as incorporating concerns regarding health equity and disparities, which is a significant and a growing thread, thankfully, in medical education.
Yes, thank you. And I want to thank everybody for this incredible day. And I'm very, very grateful that health equity and patient-centered care has been a theme throughout this day. That feels really good to have that opportunity to have that forum. But you did ask about the provider side. So I will turn my remarks to the provider and the workforce development side. But please know, really, the ultimate goal is to find that balance of design. The theme of what I wanted to react to today is scale and pace. and how we are trying to adopt scale and pace with the provider side is also as we are trying to train and educate the next generation of clinicians. And the very interesting opportunity that we have through the pandemic, but also what we were working on before that related to educating providers, physician, nurse practitioner, PAs, and others. Just on scale and pace, from a Reactor panel standpoint, my coalition response would be, please help us look for other learning in other industries even about how they have adopted technology at the pace and scale that we've now been asked to do. I'm so curious about how quickly we've had to adapt our training materials. So we used to do shoulder to shoulder education with providers and have a very customized approach. Can't do that now at the scale that we're looking at. That's come up before. I'm struck, Karen, by your comment that providers might not be providing the right education for their staff. That came up to support the consumers. That's related to scale and pace. So I think that I would be curious as a coalition how we can share best practices on those education pieces. I want to speak specifically to the workforce issues that you brought up. I would say that the accreditation for medical schools is looking at competencies. That was a remark made earlier, and that will play out in all provider education areas. But what was so, I don't mean to focus on the pandemic, but we had to immediately adopt how we were going to integrate education. So now we went from a very small population of a modest population of our residents and our learners who had exposure to telehealth. They all had exposure while they were learners, but now they had it daily. I mean, it was amazing how now they just assume they're going to be using technology as part of their practice, where it was it was an important exposure. Now it's integral to their practice. So we had to quickly develop training materials that things you don't think about, like how do you, when you walk in, if you've ever had an appointment with a learner, they take a history and then the preceptor comes in. We had to deal with that by video, turning off the camera, turning on the camera, getting in and out of rooms. It was a fascinating, again, scale and pace for us. So my final comment will be about what we call the incumbent workforce, and I mentioned that in terms of that shoulder-to-shoulder education. I think that the more that we can integrate the consumer-driven care, the consumer-driven focus into that provider education, I definitely want to participate as a member of the coalition on bridging that divide, not to use that term over, but what's happening on the provider side is now, because of the scale that we are using telehealth, we have hundreds of providers thinking of creative ways of using it. And so we need to really manage that. Thank you for, I mean, that's an exciting opportunity of embracing technology, but it's very difficult to manage in terms of having consistent training and consistent best practices. And so I really appreciate the opportunity to leverage the coalition to have those conversations so that we can work with our providers and meet the needs of the consumers.
No, Jan, thank you very much. I think what you mentioned is very exciting in terms of we have to have our physicians be advocates and other providers, non-physicians as well, obviously, but to know when to use telehealth appropriately. So I think it's a wide open area in terms of education. So very exciting future. Looking forward to hearing more from you. I'd like to turn to Frank. You know, we've mentioned obviously quality, integrity of delivering telemedicine metrics, and would like to hear what you've learned the past several months, especially in contrast to previous years of experience, in terms of what you've learned in terms of quality metrics, where we go forward, and how you can inform where the coalition should be going and trying to provide data and to support those concerns regarding telemedicine.
Sure. Thanks, Anthony. And as you referenced, or you may have referenced earlier, and I believe the audience has a copy of our task force report, but NCQA co-convened a task force on telehealth policy over the summer. We brought together leading practitioners, telemedicine platforms, health systems, all plans, all sorts of stakeholders in this. And one of the areas in which we focused was quality measurement and data flow for telehealth. Another was program integrity. And the third was around the cost of care and really getting our arms around how you measure the cost of care for telehealth, particularly vis-a-vis in-person visits. One thing that came clear and remains a challenge is that it's oftentimes hard to discern what was a telehealth visit. It's not as straightforward as some might imagine, that particularly where we are in the, we NCQA are in the data pipeline. It may well be that plans are tracking that closely and particularly pre-COVID reimbursing based on the modality. But oftentimes we get data that is really not rich enough to say this was a telehealth visit. And so that creates great challenges. Now, one of the things NCQA has done to address that challenge is to amend many of our HEDIS measures. We're the stewards of the HEDIS data set that plans in particular often report on. Amend those standards to include telehealth, meaning that one can satisfy a standard and get a point in the numerator, if you will, for having done the right thing in a given case by doing so via a telehealth visit in certain areas. And obviously there are areas that are more or less interchangeable in terms of a telehealth visit versus in-person. So that requires a great deal of focus and digging into the specifics of specific situations and diseases and standards. Jana's point was an interesting one in that while creativity and dynamic interventions using telehealth, particularly during COVID, are welcome and have been positive, we're an organization, NCQA, is that loves standardization, that believe standardization is really essential to measuring in an apples-to-apples fashion and truly determining if care is high quality. And so all of these variations complicate that process. So that's another thing we learned about measuring telehealth quality. I guess what I'd say on the program integrity side, one of the things the task force concluded is that there may be ways in which telehealth is less prone to fraud, or at least that fraud or improper use is more detectable in telehealth because of the digital fingerprints, if you will, that a telehealth visit can leave. So I think there's a lot of work to be done and exploration to be done around how you leverage the technology to actually make program integrity even stronger via telehealth. I'd say the same for patient satisfaction. We sort of dipped a toe in the water with our task force recommendations around might we do patient experience measurement a little different via telehealth. It would be a lot more real time than the current CAP survey. It could be much more actionable. It could be much more targeted if we're able to do it electronically, either in the course of a telehealth visit or soon after. We have a closer connection that we can utilize to get that kind of feedback. And so that's something where we recommended that the feds and private plans look into in terms of leveraging telehealth capabilities.
No, Frank, thank you very much. I think we all struggle. I always find it interesting. We're trying to measure telemedicine, but we're still trying to struggle how to judge and grade medicine in general. So it's almost as if telemedicine is, being asked to sort of reach a higher bar that we're trying to justify and show quality in everything we do. Not to discount that, but it's very interesting.
Yeah, I will say that was a point that was consistently heard from the telehealth platform vendors, as well as the practitioners we had on the task force. They said, look, you can't hold us to a higher standard. We should certainly be held to the standard of care. And there are maybe specific situations where telehealth is being provided where the standards might be different, although that should be the exception. But yeah, the how you measure that and how you measure it fairly for both the practitioner and the patient is a real quandary sometimes.
Yeah, no, thank you very, very much. So Bill, I'd like to turn to you to follow up on this. We focused quite a bit on payment parity financial barriers to conducting telemedicine. I'd like to hear what your perspective is in terms of value-based payment and how that fits in with regard to providing telemedicine services.
Thanks. Yeah. So I represent multi-specialty medical groups and independent practice associations across the country that are primarily paid through a prepaid mechanism called capitation. So it's a per member per month, or it's a percentage of premium. And so it's a fixed budget in terms of the patient population that's assigned to you. And so the question becomes, how do you implement telehealth in that kind of an environment? Pay parity doesn't always even equate. For example, if the physician group of 1,000 doctors is receiving a fixed budget through capitation on a monthly basis for its patient population, you may not necessarily be reimbursing the frontline providers on a fee-for-service basis. So pay parity doesn't even become an issue. If those providers are subcapped or if they're employed, it doesn't matter. And so what we saw when the pandemic began was that the large multi-specialty medical groups, mainly the ones that are affiliated with larger hospital systems in an integrated model, became very rapid adopters. And a lot of them already had the technology. It had been deployed, sort of. And then when the pandemic hit, it was mass deployed. Groups were rolling it out to all of their physicians in a weekend or over a work week. And it worked well in terms of immediate adoption. They now have to move into implementation phases and figure out how to get to an innovation phase. When you start talking about virtual networks like independent practice associations, it is much more difficult to think about how you integrate it into a value-based model. So if you are paying capitation to an IPA, the IPA might be subcapping its primary care doctors, or it might be paying them on a fee-for-service basis. And so then the pay parity issue comes front and center. And there are a lot of pros and cons to pay parity. If you assume that the pay parity is going to incent the independent physician to adopt telehealth where they haven't used it before, that's an assumption. There are a lot of factors for independent physicians to really jump into telehealth at this point in time. There are just as many issues around the multiplicity of standards that they have to meet with different payer lines or different business lines like Medicaid, Medicare, commercial HMO, PPO, the different plan standards. It's the administrative hassle, the regulatory hassle that is creating such a high burden, almost as much as the payment issue. But a lot of physicians report, a lot of independent physicians report that they're turned off by telehealth adoption because many payers want to pay them less. And so you look at it from the provider perspective, like some of the other panelists have commented upon here. If you are an independent provider in a brick and mortar practice and you're asked to deliver telehealth, that's additive to what you're doing already. So certainly, if you're being paid on a fee-for-service basis, you can get some level of compensation when you get to pay parity. On the other hand, if you are an independent specialist, in the long run, what concerns me about the pay parity policy is that something that Ken Kaiser commented upon earlier today, that 8% of practices across the United States had closed down during the pandemic. I'm interested to see the source for that data. As older specialists start to drop out of the workforce, we lose a lot of potential for virtual access that could really benefit value-based care models. But also pay parity can disincent providers from keeping brick and mortar locations open and providing inpatient service. And we have so many complex network adequacy models now between Medicaid, Medicare, and different commercial payers. I'm concerned that certain subspecialties are drawn away from in-person access and are drawn solely into virtual care. I've seen this with psychiatric practices across the country, for example. So it is a real concern. Integrating them into a value-based model, though, is a priority. And I think there's a couple of pathways to consider here. Payment reform should transition out of fee-for-service to outcome-based payment models. If you are truly on an outcome-based, value-based payment model, then it's up to the provider to determine how to deliver the services in a way that optimizes the outcomes for the patient, because their reimbursement is based upon that. One of the things that telehealth does for that type of provider who's in that transition payment model is it does provide an ability to get immediate input from a patient in terms of patient satisfaction with the visit that you don't get with in-person visits in the old brick and mortar location. So there are ways to craft incentives in a value-based model to focus independent providers on making this transition to a virtual model, at least a partial virtual model. There was a panel discussion earlier today where there was a discussion about what's the optimal mix between telehealth and in-person visits at the individual provider level. And that is the big question right now. It's difficult for providers to rearrange their schedules to do both. It's a challenge for them. And so they're going to need more training, just as they needed training 20 years ago in terms of adopting advanced access scheduling for their practices.
No, Bill, thank you very much. It is complex, and it just throws sort of another tool in the armamentarium. Lene, I think I really look forward to hearing some of your comments specifically around reimbursement for telephonic only visits. And I think I sort of view this as a stopgap. I mean, we all identify the resources that we need to get out to all our patients to avoid disparities in access, but I'd like to hear what your perspective is in terms of how we should approach telephonic reimbursement and what you see as the near future for that.
Yeah, thanks so much for having me. Linnea Koopmans, I'm with the Local Health Plans of California. We're the statewide trade association that represents the 16 nonprofit community-based health plans that collectively serve around 7 million Medi-Cal managed care beneficiaries. So that's about 70% of the total Medi-Cal managed care enrollees. So I think maybe just to start off, I think like many others have expressed today, I think we agree that the option to obtain services via telephone has really helped ensure that Medi-Cal beneficiaries can access care during the pandemic. And we also acknowledge that there's times where telephonic care is actually preferred by the beneficiary and is an effective alternative to in-person or audio-visual services. And I think the example that's come up a number of times today is mental health services or behavioral health services. And we've heard the same thing from our local plans that many of their members have received care through telephonically throughout the course of the pandemic for their mental health needs. So overall, I think we're supportive of the modality and reimbursement for it, but I think now it's a matter of how do you square that with the structure of the Medi-Cal program post-pandemic, when a lot of the other kind of regulatory flexibilities or rules that have been relaxed are back in place. So I think with that in mind, I'll just touch on very briefly on 4 issues or questions that local plans have or are discussing about the appropriate role of telephonic care, both from a clinical and cost perspective. So first, I think one of the things we're thinking about is whether there should be more specific policies around which services or which types of services are appropriately delivered via telephone versus audiovisual or in person. So while I think we understand the importance of clinical judgment and flexibility, we also, I think, wonder if that should be balanced by a consideration of parameters or guardrails. So again, just something we're talking about and considering, don't necessarily have ideas or answers at this point. Second, we have questions around how providers are mapping telephonic visits to the appropriate level of care and really determining what is the equivalent in-person service. So I think we've heard a bit about that today as well. And then third, I think Frank's comments really resonated with me because a lot of the conversation that I've been hearing among my plans in terms of how does telehealth translate into quality measurement and reporting. And so I think as plans, we want to ensure that to the extent that services are delivered via telehealth, that those are adequately captured and counted in the plan's quality measures. So Frank referenced that earlier this fall, that NCQA updated their measure specifications or instructions for how plans are to report on certain measures when that respective service was delivered via telehealth. So we've recommended to the state and think it will be important kind of ongoing for the department to really look to these national guidelines and adopt them. Particularly given that a lot of the measures in the managed care accountability set, the quality measures are HEDIS measures for which NCQA is a steward, and a lot of our plans are also NCQA accredited. And so that's third, and lastly, I do think we have some concerns that payment parity for telephonic care might incentivize phone visits when audiovisual or in-person would actually be more appropriate. But I think at the end of the day, broadly with payment parity, I think our big question is what is the state willing to fund? So as contractors with the department, I think we, like everyone else, are very curious to see what is or isn't in the January budget. And I think, it's a matter of whether they're willing and able to fund the increased reimbursement for telehealth services on kind of an ongoing or permanent basis. So again, overall, I think we support the modality of telephone and are just thinking through how does this translate in a post-pandemic environment.
No, Linnea, thank you very much. It's a complex topic, just like so many of these. I want to thank all the panelists. We have a couple questions we can address in 2 minutes. I think we all agree we could probably have this group speak for hours and people would stay engaged. One of the questions was asked in terms of what is telemedicine doing in terms of addressing patients with disabilities? And I'd like to hear, briefly from any of the panel members who have thoughts on that or any solutions that they're aware of.
Hi, this is Fabiola. So we work on Medicaid, and we work on Medicaid in several states. And one of the examples that I wanted to offer as we're thinking about innovative solutions is the ability of certain Medicaid programs to offer devices. So in New Mexico, actually, New Mexico submitted an Appendix K waiver, which is a waiver for home and community-based services, where people with disabilities can have access to tablets. So the examples do exist of certain Medicaid programs asking the federal government for permission to be able to pay for certain specific devices for people with disabilities, or frankly, anyone who really needs the devices. So I want to offer that as an example.
Great. And I don't know if we can sneak in one quick question. I think this would be addressed to Bill. How do you give providers credit for telemedicine in a value-based payment situation?
Yeah, I answered that in writing as well.
Okay.
Let me see if I can answer it closely verbally again. There's a lot of ways to do that. One is you have to transform the payment model to be outcome-based. It has to be prioritizing patient satisfaction and timely access to care as the chief elements of the payment model. When you do that, you create a budget for a provider to work under and reorganize their practice in such a way that they can deliver the virtual visit as well as the in-person visit in a proper mixture that works for them. Not everybody can do it 50-50, 25-75. It'll depend on the individual provider's practice and capabilities. That's one way to do it. Another way to do it that I included in the response that I've seen done with EMR adoption and with practice management system adoption across an entire independent practice association with independent doctors is for the IPA at the administrative level to kind of bear the cost burden of rolling out those systems, of training the individual providers, of being there to hold their hands and getting those systems up and running in their offices, and making that decision as a collective group of providers to spend that money for those purposes to kind of rise all the boats to the same level, right? That works as well. And I think that's going to be a good model for telehealth adoption. I've seen this happening over the last few months with some IPAs across California, and I'm very positive about that.
Thank you very, very much. I, again, really want to thank all the panelists. I think this is a fantastic panel, and it raises many questions as we answer, but we get a lot of great information. So thank you very, very much, and I'm going to turn it back over to May.
Thank you to all of our panelists, and thank you to Dr. Magid for moderating that particular panel. I'm going to ask our new legislative committee chair to join us. Lisa, are you on? Hi there,
everybody.
Thank you. So we're going to do a quick poll here. So if you could just take a moment to respond to that. Okay, so this is for your top priorities that you think the coalition should pursue next year, and they keep shifting a little. So I'm going to give it a couple more seconds here. All right, what do we have? So right now, the one that it actually got pretty close between the first three slots there, but the one that came out on top was make temporary changes permanent and expand access to new modalities. To bridge the digital divide and address health equity came in second, a very close second. There was only about 9 percentage points separating them. And then build the evidence base came in third, and then advanced state telehealth leadership in telehealth and health IT. So those are the rankings that we have of our priorities going forward. Lisa and Dr. Magid, Dr. Magid, if you can come back on here. I'd like your thoughts on like today. It's been a pretty rich and packed day. I know people are probably a little bit tired. It is a little bit long to be on Zoom for so long. But if we could get just some initial reactions from you both for today's meeting.
And I think the importance of sharing information. I think all the hard work that Robbie, May, Aaron, Julie, Timmy have done, I think providing information across the state is critical. I think that's what clearly is, and as we come up with some good metrics and data that we share it, and I think we've also discussed in the past standardizing some of our questionnaires both for the providers and the patients, I think is very, very important, because I think that can really influence in what direction we go as we get a better assessment of how people interpret telemedicine, are satisfied with it, and matching that up with objective outcomes.
Okay. Lisa?
Yeah, so I mean, I think that, I think first off, May, you and Blue Path and your staff has done such a great job for organizing this meeting. And I think for me, the takeaway from today is really I think the topics today and the speakers today really reflects how, you and Mario have really built this coalition, and that, our telehealth policy really needs to be looked at holistically. And I think I was really happy to hear so many of the speakers talk about the importance of this work being viewed through a health equity lens, And I really do think that our long-term goals, not just with telehealth policy, but healthcare just in general, really needs to, get at that systemic racism within the structures that continue to exacerbate the disparities that this pandemic has really brought to the forefront. And, I think, Vice President-elect Kamala Harris was saying how, this virus has no eyes, and yet it knows exactly how we see each other and how we treat each other. And, I think just even that poll just now shows, right, that those things, they go hand in hand. It's not really one or the other in terms of our priorities. So.
That has been one of the things that has struck me about during this time as we've gone forward on telehealth policy during the pandemic. It's always been something we've discussed, the disparities, the health disparities. It's always been there. We've always discussed it, but this pandemic has definitely highlighted it and really put it forefront in all of our minds that this is something we really need to consider as we go forward with our telehealth policy agenda.
Yeah, and I think this group has really been great just sharing information too, because you're right, May, we've been talking about it for a long time, but it has really allowed us to pinpoint exactly where the work needs to be done. And so that's been really helpful.
And that's been really because the coalition has had this broad reach of membership of like so many different groups. If you look at who is a member of the coalition, it is from almost every walk of life there. We have, like consumer groups, we have health plans, we have tech vendors, we have providers and clinics and hospitals and other groups like, specific population people they represent, and they all provide a voice into helping, trying to build the best policy possible, because if it doesn't work on the patient end, it's just not going to work. So as we start closing up, I'd like to hear from you both as our incoming chairs, what your thoughts are for a call to action for 2021. We've got a lot of work ahead of us. So what are some of the words of wisdom you guys can impart on us? So Dr. Majid, I'll let you go first.
I was gonna build on a comment that was made earlier. I think health equity is incredibly important, and not widening the divide, because somebody alluded to the fact that as we move more resources online, if we get people to maintain that percentage of care, there's that risk of decreasing brick and mortar facilities and in-person care. And I can tell you, in talking to some organizations, part of their business plan is to eliminate some of their brick and mortar facilities and transitioning to telemedicine. So not only do we run the risk of telemedicine itself widening the disparity if we don't get adequate technology, education, translation to our patients, but we do run the risk of potentially reducing how much in-person service is actually available specifically for ambulatory care. So it works in both ends. If we're going to pull away, we need to make sure that we're serving everybody equally.
True words. Lisa?
Yeah, I think just looking forward to the 2021 legislative session. It is going to be a first year of the 2-year session, and we expect, given some of the vetoes that happened on some key pieces of telehealth legislation, and also this, I think one of the speakers says, we're not snapping back to normal times. Like, there is really no going back, right? And so expecting that there's going to be several pieces of legislation related to telehealth and broadband this year. I think the legislative committee is ready to push telehealth policy that's supported by this coalition. And in addition, we're going to, obviously monitor and provide input and guidance on proposals that are not just coming out of the legislature, but also the state agencies and the administration, frankly. I think, there appears to be some common ground that ran through many of the speakers today. I do want to acknowledge to everybody that, it does look like the budget is not as bad as the Department of Finance initially projected, but it's still not going to be really very robust. And I think what we are able to accomplish is going to really depend on what the state's willing to pay for, but also on the ability for providers and patient groups and health plans, like everybody in the healthcare industry, to really show what the value is in telehealth. And I think, Dr. Majid, you're completely right. We want to make sure that the policy isn't going to swing so far to one end that it's actually going to exacerbate the disparities. We want to make sure that it's thoughtful and we're thinking about it from all sides. So I really look forward to working with all of you to providing our policymakers in the state with, not just the data, but like the patient experiences, what our priorities are, and as well as our expertise to advance some of the telehealth policies in a real thoughtful way.
Mm-hmm. I'm struck by something that Assemblymember Aguirre-Curry mentioned in her talk, where she said that we were considered, a leader in telehealth policy, one of the most progressive states. And really, in February of 2020, we were. Medi-Cal had done like that huge policy update. It was the most progressive Medicaid policy in the nation. AB 744 had just passed. So we were actually in a good position. But even, excuse me, even when Excuse me. I am a serial sneezer. My apologies for that. But even when COVID hit, California still was not ready. I mean, and compared to the other rest of the nation, and a lot of places, we were like a lot more ready than they were. But still, we were caught flat-foot. Granted, it's because none of us had anticipated a pandemic. But where telehealth policy was concerned, there was still a lot of work that the state had to do, even with all those great progressive policies that we had just passed a few months before and gotten implemented. So I think it speaks to like how much work is ahead of us going into 2021. And now it's also been brought to light all these other issues that we've been talking about today that you two touched upon, the disparities, making sure we don't exacerbate that, to look for and be very mindful and thoughtful on like how we go about this. And I feel very reassured by how big of a coalition we've built. So we do have all those many voices in there to remind us of like, yes, we go forward this way, but don't forget that this is how it's going to impact this group of folks here. So we need to be very mindful of hearing all those different voices. And I think that's what makes the coalition unique. However, I think it's also been very telling, the fact that we were caught flat-footed by this pandemic, that it's no longer a question of whether telehealth is right. It's a question of like, we need to do something right now, because we can't afford to wait to see like, oh, well, let's just, see how this goes for like another 2 or 3 years with this pilot, because there are people who need these services. We just have to make sure that we do it in the correct way and that we don't leave anybody behind or we make anything sort of worse for somebody's situation. But we do need to have some action now. So I am going to call on everybody who is a member of the coalition who's been on here today. If you are not a member of the coalition, I highly recommend that you join, that you participate in the committees that we have, led by these two wonderful people here, the Legislative Committee by Lisa Matsubara and the Education Committee led by Dr. Majid. And I also ask that you participate in the coalition. We have our monthly meetings, we have monthly committee calls. We do not take attendance, so if you miss a call or miss a meeting, don't worry, we're not going to penalize you. But we do need to hear your voice. We do need you to participate on there. And we hope that you'll be able to help us as well as we try to get our messaging across. And if you're able to provide financial support for the work of the coalition, that would be great. But also, just as importantly, it is your knowledge, it is your participation, your time that we value as well. So I want to again thank you to our great incoming chairs. Thank you to our outgoing chairs, Erin Kelly, Julie Bates, Amy Durbin. I also want to thank our sponsors and our supporters who helped us put this on today. The California Healthcare Foundation, who have provided years-long support to the coalition. Buckalter, who was one of our gold sponsors. Our silver sponsors of AARP California. Our bronze sponsors, Hims & Hers, West Health, and HealthNet, and our champion, Alliance for Patient Access. Also want to thank all of our speakers and our panelists, especially our former champion of 2019, Assemblymember Aguirre-Curry, and our current champion, Dr. Chan. I want to thank all the attendees. It's been a long meeting, but I thank you for attending and sitting through this. I hope you found this useful. Please note that we have our December meetings. Our Education Committee is meeting on December 9th. Our Legislation Committee is meeting on December 10th. These are Pacific times, so if you are not in the Pacific time zone, note these are Pacific times. Our monthly meeting will be on December 18th. I know it's very close to the holidays, but we have a lot of work going into like the 2021 session, so we'll need to definitely meet in December as well. There will be an evaluation after this webinar. We hope that you fill that out. That'll be very helpful for us to hear your feedback. Please know that if you have any questions about the coalition, you can reach out to me. I'm May Kwong at the Center for Connected Health Policy, or you can reach out to Blue Path staff as well. I do also want to acknowledge and thank Blue Path Health for their work on this. Golden State Health Policy, Karen Shore and her staff for her help in putting together this meeting. CCHP staff, Veronica Collins and Arya Javidan for their help in getting this meeting together as well. And thank you once again to all of our speakers, all of our committee chairs, all of our sponsors and supporters, and all of you. Have a great day.